Welcome everyone to the second part in a series of muscle tone and tone management dynamic seating intervention. My name is Michelle Lange. I'm an occupational therapist in the Denver, Colorado area. Let's go ahead and jump on in. So in this series, in part 1, we covered what is muscle tone, what's the pathophysiology, the etiology, etc. And we talked some about tone management strategies and how these impact seating interventions. In today's course, we're going to be talking about common positioning challenges and strategies that are used when choosing a wheelchair seating system for someone with increased muscle tone. And then in our third portion of this series, we're going to address various dynamic seating interventions. Now, when we're positioning a client with increased muscle tone, that tone is going to impact the seated position. And once we select the ideal position in an effort to manage that tone as much as we can, we need to choose seating components that can help us to achieve and sustain that position. So let's talk about some of these common challenges we see when positioning someone with increased tone. Well, with the pelvis, we often see a posterior pelvic tilt, pelvic rotation, pelvic obliquity, and occasionally pelvic anterior tilt, though this is not as common in people with increased tone. So what can cause a posterior pelvic tilt? Well, a lot of our clients have a posterior pelvic tilt, and this is very common in people with tone. Oftentimes they are using an extensor thrust and pushing right into this position. This position can also be caused by low tone in the trunk. We know that some clients who have increased tone in their extremities may have low tone in the trunk. It could be those hamstrings are tight. Those hamstrings cross the pelvis and the knee, and this can be a problem. The seat depth might simply be too long, regardless of someone's muscle tone. There may be limitations in range, particularly in hip flexion. The client may slide forward on the seat or actively thrust. And if this person happens to be on a sling seat and back, well, it's pretty hard not to sit in a posterior tilt within those surfaces. So let's start with people who have low tone in the trunk, and it could be that gravity is just causing everything to collapse. Again, this can occur even in clients who have very high tone in their extremities. So what can we do? Well, a lot of positioning is really force and counterforce. And in the case of the pelvis, we need to make sure this client has adequate support posterior to the pelvis and anterior support to prevent those ITs from rotating forward, those ischial tuberosities, and a appropriately angled pelvic belt is a part of that solution. So let's start with some of these posterior support strategies. We need to make sure there's good firm support behind the pelvis. This can sometimes take the form of a biangular back or even a pad like this one. This is just on a seating simulator. We used to slip this in to simulate a biangular back. It's just a pad that goes to about the top of the PSIS. Sometimes we can drop the knees a bit in relation to the pelvis. That creates a bit of an anterior slope to the thighs and can pull the pelvis forward into a little more of an anterior tilt, opposite of that dreaded posterior tilt. Now, there are a number of off-the-shelf backs that emulate the shape of a biangular back. If we look at a linear back where the primary purpose is a biangular back, we see what we have here on the right. We have the lower portion that goes up to the top of the pelvis, about the PSIS, and this angle is often closed to about 90, maybe 95 degrees. But above that, the back angles slightly outward to open the angle, and that promotes trunk extension while keeping the pelvis in a good position. If this uses fixed hardware, usually this angle is about 7 degrees, but there's adjustable hardware as well. You can customize to your individual client's needs. And again, some other backs, including if we do a molded back, may end up with this shape to keep the pelvis upright. What about those clients with tight hamstrings? I don't know about you, but it feels like most of my clients have tight hamstrings. The hamstrings again cross the pelvis and the knees, and so our strategies here are to open the seat to back angle a little bit, relieving the pull on the hip side of those hamstrings and reducing the angle at the knee, pulling those feet back as much as those front casters will allow, and that helps pull or relieve the pull on the knee portion of the hamstring. Let's say someone has limited range of motion at the hips, particularly hip flexion. If this is limited, we'll notice that during the mat examination, as we try to flex those legs at the hip, that the pelvis will rock into a posterior pelvic tilt. And this is because the person just simply doesn't have enough range. So it's important that we determine on the mat exam how far can I flex the hip before I notice that the pelvis is rocking posteriorly. At that point, I need to back off a little bit, note that angle, and make sure that the seat to back angle of the seating system does not assume an angle that's more closed than the person's available range. So this is usually accommodated for with a more open seat to back angle. Sometimes we have clients that just slide forward on their seat. With this population of people with increased tone, this is often the result of active extending. Sometimes it may not be very obvious. I look at a client, they seem to be upright in their seating system. I turn my back, look again, and they've slid forward. So what do? Well, we can provide something called an anti-thrust seat or use an aggressively contoured seat in order to block the forward movement of the ischial tuberosities. We can stabilize the pelvis, usually in combination with this shaped seating surface, using an appropriately angled pelvic belt. We could even use a rigid anterior pelvic stabilizer. These aren't as common as they once were. Sometimes simply changing the upholstery can help so that it's not as slippery for this individual. Now you can see in the lower left here that this is demonstrating how an anti-thrust works. So there's an anti-thrust curb that's placed just in front of the ischial tuberosities, the ITs, because a posterior tilt is a rotational movement. It doesn't just move straight forward. We want to stop that rotation, and if we can block forward movement of the ITs, this can be very effective and is often combined with a biangular back. It's important this curb is in the right location. If it's too far forward, the client will simply rotate until they meet that curb and then stop. Many clients can jump up and over this curb, and so an appropriately angled pelvic belt is real important, and we'll talk about that just in a moment. Many off-the-shelf cushions combine materials and use a design that mimics this anti-thrust shape as well, and allows us to provide a combination of pressure relief under the ITs, but using firmer materials throughout the rest of the cushion to help with positioning. So what about that pelvic belt? Well, the best angle for keeping the pelvis from assuming a posterior pelvic tilt is typically 60 degrees. We work with individuals, so we have to make sure. But this 60-degree angle, often again in combination with good posterior pelvic support and an anti-thrust shape, is going to help keep the pelvis in position. If we use a belt that's mounted much higher than this, say at 30 degrees, we're actually pulling the pelvis into a posterior tilt every time this is tightened. It's pulling back on the ASIS. If we go with a 45-degree tilt, well, this allows the client to rotate under the belt because, again, the pelvis isn't moving straight forward, it's rotating, and that's why this angle is not very effective. Now, it can be helpful to look at an example of this. So on the left, we have someone who is using a 45-degree angle. And as she extends, you can see that she's able to rotate under it.
Here we have a 45-degree seatbelt, which is not always successful at preventing a posterior pelvic tilt. Now the client has assumed a posterior pelvic tilt, and we'll attempt to correct this by changing the angle of the pelvic positioning belt.
So she pretty readily moved underneath that. Now let's see what she does when we've moved the belt slightly to a 60-degree angle.
Alright, we've now moved the seat belt to approximately 60 degrees to minimize the posterior pelvic tilt. And if you go ahead and try to move the pelvis, and we have significantly less movement into posterior pelvic tilt, and despite movement, the client is returning to a neutral position.
So this angle makes a huge difference. It's really important to choose the right angle. And with the mounting hardware that we have available to us now for pelvic belts, we can really easily achieve the required angle. Next, let's take a look at pelvic rotation. And keep in mind that these various challenges can be seen with each other. So we may see rotation in combination with pelvic posterior tilt, for example. So what causes pelvic rotation when one side of the pelvis is forward of the other? Well, it's usually due to range of motion limitations. Either there's a lack of range in the adductors, the abductors, hip flexion, or the client is assuming a windswept posture. And our friend here is showing us that windswept posture where one leg tends to be adducted and often internally rotated. The other leg is abducted and externally rotated. So what do? Well, we want to keep the pelvis in neutral rotation. If we're able to correct the legs in alignment with the pelvis, once the pelvis is in a neutral rotation, great. If we can't, if we have to allow those legs to go to the side a little bit in order to maintain a neutral pelvic rotation, then that's what we're going to do. So with this young lady here, I could certainly swing her legs in front of her and straighten those out, but it rotates her pelvis because of range loss. So we have positioned her so that her pelvis is in neutral rotation, as neutral in alignment as we could achieve in all planes, and we are allowing this asymmetry of her legs in order to maintain a neutral pelvis. Now, sometimes we have causes of pelvic rotation that are fixed, non-reducible. It could be there's changes in the spine, the pelvis, femoral mobility, and this is leading often to a spinal rotation that subsequently leads to a pelvic rotation. Now in this case, sometimes when we straighten out the pelvis, the person who is seated is now facing off to the side, and we don't want this person facing their world from an angle. We want them to be able to face their world face on. So in this case, we may allow the pelvis to assume some asymmetry, some rotation, if this is what's required for the person to face forward. We just have to make sure the seating system is providing adequate pressure distribution, particularly on the posterior pelvis. Pelvic rotation can be caused by tone and by reflex activity, particularly that ATNR, that asymmetrical tonic neck reflex. Here's my friend Lynette, and you can see she's really showing off that ATNR. She has a lot of extension on the right side of her body and a lot of flexion on the left. Why? Well, she does have an ATNR, but she's using her ATNR to reach her joystick. And so one of our solutions in her case was not just to look at her seating system, but also her driving method. We changed her driving method and she was able to drive without eliciting this reflexive response throughout her day. So what do we do in this case when we have a lot of tone and perhaps this ATNR that's driving the pelvis forward? You can see here that Lynette's right side of her pelvis is quite forward of the left. Well, in general, when we position someone in some lower extremity abduction and flexion at the hips, the knees, and even the ankles, we can break up tone a bit. Just like when we're transferring someone, we use certain strategies so that our client is not straightening out during that transfer. So some of that can be helpful. A real simple solution that I use all the time, if this is a reducible pelvic rotation, is I make sure the pelvic belt is pulling down on the forward side. So imagine that Lynette's pelvic belt pulls down on the left. Every time a caregiver puts her in her chair and tightens that belt, they're reinforcing her tendency to pull back on the left and be forward on the right. Where if we flip that belt around, now we're pulling down and reducing that rotation every time the person is placed in their seating system. So this can be part of our solution. And then we have pelvic obliquity. In pelvic obliquity, one side of the pelvis is higher than the other. This is often seen with other pelvic asymmetries as well, such as a posterior pelvic tilt. This can be caused by a scoliosis, a lateral scoliosis that pulls one side of the pelvis higher. This can be a component of an ATNR. It could be the result of some surgeries to the spine or the hips that have left someone with a certain degree of pelvic obliquity. Sometimes this is discomfort. Someone may have a really uncomfortable hip, and as a result, they're trying to unweight that hip, and this appears as a pelvic obliquity. And then finally, if somebody has a cushion that's just kind of tossed on top of a sling seat, it often falls off of one of those seat rails and ends up oblique. And of course, the client as a result will be oblique as well. Pelvic obliquity. So where do we put the pelvic belt in someone who has pelvic obliquity? Well, the best way of positioning this belt is over the lap, just in front of the ASIS, like we see here in this middle picture. This pulls down the leg on the high side and as a result pulls the pelvis down. This relies on the integrity of the hip joint. If someone has a dislocated hip, pulling down on the leg bone will not pull down on the hip bone, and so we need to find other strategies. If there's also rotation or a posterior pelvic tilt, we may use a 4-point belt because now we have two different angles we can take advantage of. So one angle could be at this 90-degree angle over the lap, but the other could be more at a 60-degree angle. There is a primary and secondary belt, so you have to decide what is the chief problem. Is obliquity more of an issue than the posterior pelvic tilt or harder to control? If it is, then we want the primary belt over the lap and the secondary belt at 60 degrees. Now, what do we do besides the angle of the pelvic belt if this is flexible or reducible, meaning that with some manipulation, I can get this person to a neutral level of obliquity, but their tendency is for one side to be higher than the other. In this case, we place a wedge under the low side. So if we look at the picture here on the left, the left side of the pelvis is high, right? So we put a wedge under the low side to even out the pelvis. This is a tricky dance. We have to really get a good feel for where the pelvis is and determine if we have the right amount of wedging under the low side. Now, we never want to put that wedge right under the IT. That wedge is usually a firm material. We don't want to cause pressure. It goes under the seating surface itself, under those more forgiving materials. But if the obliquity is fixed, I cannot reduce it. This is where it is. Then we wedge under the high side. We're not trying to move the pelvis at this point. We're just trying to better distribute pressure. So at this point, one of our gauges of whether or not we have appropriately filled in that space is a pressure map. I don't use pressure maps a lot in my practice with the clients that I work with. Many clients with high tone are not at high risk for pressure injury because they're kind of doing many weight shifts all day long. But a pressure map can let me know if I've wedged this enough to even out the pressure as much as possible between the two ITs under the pelvis. Let's talk about positioning challenges we may see at the trunk in people who have increased tone. And these include lateral trunk flexion, forward trunk flexion, trunk extension, and trunk rotation. These can be flexible or reducible. They could be non-flexible or fixed, sometimes called non-reducible. It could be that these are seen in combination as well. So let's start with kyphosis. Kyphosis can be seen at various levels of the spine. It's usually in the thoracic area, but we really can see this highly flexed area in the cervical area and even the lumbar area as well. Again, this can be flexible or fixed. Sometimes part of the curvature is flexible. I can correct it partially. And it may be combined with neck hyperextension because the only way the person can really look upward from this forward flex position is to hyper. This forward trunk position can be caused by numerous factors. There could simply be a lot of flexion happening at the hips. It could be there's active flexion at the thoracic area. It may be that the shoulder girdle is collapsing downward with the influence of gravity. It could be, again, that we have low tone in the trunk, even if there's high tone in the extremities. Perhaps the abdominals and or back extensors are weak. It could be that increased tone, for example, in the hamstrings, is pulling the pelvis into a posterior tilt. It's really hard to not sit with forward trunk flexion if you have a posterior pelvic tilt. And some people assume this position in an effort to find stability within the seating system. In this case, we need to make sure they have adequate stability within our seating interventions. So if this is flexible, I can bring this person to upright, then I need to look at a combination of anterior and posterior trunk supports. Again, force and counterforce. There's lots of anterior trunk supports out there. There's chest straps, shoulder retractors, butterfly vests, abdominal supports providing more of a belly binder kind of approach, and even orthotics such as a TLSO. Each of these are designed to address slightly different issues, but in general to prevent forward flexion. If there's a lot of flexion in the upper trunk, usually shoulder straps are going to provide the most trunk extension and scapular retraction in comparison to our other options. But we have to remember posterior trunk support as well. This will not only allow us to help correct a flexible posterior tilt, but also increase overall trunk extension. Again, the lower portion of the back has a tighter seat to back angle to keep the pelvis in a neutral rotation. But as the upper back extends beyond that, we're promoting that more extended trunk position, and that, of course, is going to counter that kyphotic tendency. Now, what about someone who has a fixed kyphosis? And this is very common in our older population. In this case, no anterior support is going to correct this forward trunk position. It is still important to have appropriate posterior support. This might need to be a more contoured back, otherwise we're going to have very little contact with this flexed trunk and the back of the seating system. We may still use anterior supports to prevent this from worsening, that we're not able to correct it. So in this case, our goal is to help the person lift their head so that they can view their environment without hyperextending, so they can swallow without that high risk of aspiration that helps with neck hyperextension. So this improves vision, breathing, and swallow. How do we do that? Well, we either open the seat to back angle quite a bit, or tilt the client, or use a combination of both. How far do we go? Well, until that head comes up. So once the head is balanced over or just behind the pelvis, that's where we need to open that seat to back angle and or tilt the client. Sometimes it looks like this chair is insanely open when the client's not seated in it, but once they're in there, it becomes clear why that angle is required. You can see for this gentleman here, Jesus, that his head support is a mile behind him. In this case, sometimes a very long horizontal bar is required on the head support. Again, this will look very strange when the client is not in the chair, but when they're in their chair, again, it will become clear as to why that is required. All right, what about trunk rotation? Trunk rotation is rarely seen in isolation. Oftentimes, this is seen with lateral flexion of the trunk, and often seen in combination with pelvic rotation. So we need to look at causes for each of these. We are going to talk about causes for lateral scoliosis here in just a minute, and we've already discussed causes of pelvic rotation. So we want to try to correct the pelvic rotation first, then address any residual trunk rotation. So again, see those pelvic rotation interventions again. And if this is flexible, it's reducible. Once we have the pelvis in neutral rotation, we can either use a simple shoulder strap on the forward side. If that is not adequate, there is a specially designed shoulder strap that's shaped like a Y, you can see it here, that helps to de-rotate the trunk. It's very important to make sure caregivers know how to use this correctly. I sometimes see these where they are on either side of the neck. You can see this is supposed to be across a clavicle and under an arm on that forward side. What if trunk rotation is fixed, non-reducible? What do we do? Well, sometimes we can place the pelvis asymmetrically. We can allow some rotation of the pelvis so that the client is facing forward. It's very important that this client can face forward for their world. If that's the case, if there's not good contact behind the pelvis and the trunk, sometimes a molded back will be required to distribute pressure. And that brings us to lateral trunk flexion, often called a scoliosis. So this may be a C curve. That C curve may quickly turn into an S curve because our body is wired to keep our head midline and upright. And so if I start developing a C curve, I'm going to try to find that upright position and I'll get an additional curve in my back. So it's important to do that mat examination. to ask if the family's had recent x-rays, because sometimes this person may appear to have a level pelvis and a level shoulder area. However, if they have a very distinct S curve, we may not realize how much curvature there is in the spine unless we get them out of their seating system. This may have a rotational component and may be flexible, partially flexible, or fixed. So what causes this issue? Well, there may be more tone on one side of the body than the other, and it's pulling this person actively into this curvature. This young man here has a tendency to collapse to one side, but when he gets excited, he actively pulls to that side. And it's important with many of our clients who have increased tone to evaluate their seating needs at rest, but also when that tone is active, so we can find a more useful, valid outcome for them. It could be there's an imbalance in the muscles. There could be, again, decreased tone in the trunk, even with people who have increased tone in the extremities, and that could be causing some sideways collapse. This person may be fixing in this direction purposely to increase stability, to kind of hang on. It could be that some fixed scoliosis has developed in the spine. So what do we do? Well, again, this is an example of force and counterforce. We can use anything from a generically contoured back, which is encouraging someone generally to stay in midline, to adding external lateral trunk supports in an effort to align the trunk, to a three-point control that we see pictured on the right here, where we place supports very intentionally to provide the appropriate force and counterforce necessary to either correct a flexible lateral scoliosis or to minimize further progression of a fixed scoliosis. We might see this support built into a molded seating system if that's required as well. If this is fixed, it's very important to work with the medical team, because once these scolioses get past a certain degree, oftentimes there will be surgical interventions. Now, not every family will choose that, and not every client is a good candidate for such an invasive surgery. But it's important to know what maybe is planned from the medical team. Depending on where you're at and what the orthopedic surgeons in your area are recommending, your client may use an orthotic to help limit progression of this lateral trunk flexion. In that case, seating is really not too difficult because the TLSO is doing a lot of the work. Without an orthotic, there's a good chance this client will need a molded seating system depending on the degree of the curve in order to provide adequate support and distribute the pressure. Otherwise, it's going to take too much pressure over small areas of the trunk that could lead to discomfort and even pressure injury. We're providing that intimate contact that's required. Now, sometimes if someone has a very significant C curve, their head will be quite to the side. We can use even a lateral tilt, either a fixed or a power one, like this one from Motion Concepts, to find the right angle where the client is able to right their head, if at all possible. This is tricky. Someone who has a significant fixed lateral trunk flexion most likely has a fixed pelvic obliquity. So now we need to balance out allowing the client to have an upright and midline head and not have too much pressure under one of the ischial tuberosities. And this is where molded seating is often indicated. Now, if these spinal asymmetries are fixed, we cannot reduce them. We may see these in combination with each other, where we have perhaps some kyphosis, some lateral scoliosis, some rotation. The curvatures of the spine are also going to impact the shape of the rib cage, and so we may have a more prominent area of the rib cage that we also need to address. Our goals in this case are to accommodate and support those asymmetries, to really distribute pressure, because in these situations, very small areas of the lateral and posterior trunk may be in contact with the seating system. That's uncomfortable and again can lead to pressure. So we need to distribute that. That's often with molded seating. Even if this is a fixed asymmetry, it doesn't mean it can't keep worsening. We just can't make it better without usually surgical intervention. So we want to minimize future progression if we can, provide comfort, and optimize trunk and head control and balance for the client. Let's move down to the lower extremities, and we're going to start with the hips. At the hips, we may see in people with increased tone issues with hip flexion, hip extension, hip adduction, hip abduction, and a windswept tendency. Let's start with hip flexion. Some of our clients tend to pull up into a lot of hip flexion rather dynamically. It may not be a range limitation, it's more of a muscular or reflexive response. It could be that there's just a lack of range there and we cannot further extend the hips without pulling the pelvis into an anterior pelvic tilt. This can sometimes be the result of poor positioning over time or poor range of motion management. So if this is flexible, we can extend the hips to a more neutral position. Then oftentimes we'll use some strapping. You can strap the top of the thighs, but usually we're going to do so over the feet. So we use shoe holders, ankle huggers, some type of strapping. If you have a client where this is just not tolerated or desired, I've had some clients where we've literally padded the underside of a tray so that when the client lifts their legs, they're not banging into that hard surface. If this is fixed, we have to respect the available range within the seating system. If we overcorrect and pull those legs down, we're going to pull the pelvis into an anterior pelvic tilt due to that lack of range. Some clients have a lack of hip flexion. They have a tendency towards extension. This is often due to increased extensor tone, and this person will lose range over time, particularly if there's poor positioning or poor range of motion management. In this client here, unfortunately, this young man outgrew his seating system. A new seating system was recommended but denied by the funding source. The family wasn't sure what to do. Unfortunately, he fell through the cracks and this wasn't pursued further. And when he no longer fit in his seating system at all, his mom put him on a blanket on the floor. And that's where he stayed for a long time. And what you see here with his lower legs is pretty much the available range he has. So now we had to look at a much different seating solution. So if this is flexible, someone just tends to extend a lot, but they can be corrected. You really have to look at the mat exam to decide what is the best angle to support this person at. Sometimes we do have to allow the seat to back angle to be a little more open. This is a time we often look at dynamic seating solutions as well, and we'll be talking about those in part 3 of this series. If this is fixed, we really can't get this person to 90, 95, maybe 100. We have to open the seat to back angle to the point of the range limitation, and that is determined on the mat exam. So we flex the hip while someone's supine on the mat table. If that pelvis starts rocking rearward into a posterior pelvic tilt, we know we've hit the end of the available range, and that's where the seat to back angle needs to be. If the culprit are those tight hamstrings, we may be able to close the angle at the knees and do some more flexion, and that might allow us to close the seat to back angle slightly. And sometimes in these scenarios, a contoured seating system will be required to help maintain someone in a position where their seat to back angle is quite open. Now, sometimes we'll be working with a client who has more flexion available on one side of on one hip than the other hip. In this case, we often want to place that one hip in a good deal of flexion to maybe 90 or 95 degrees seat to back angle in order to keep the pelvis in a more upright position, to keep the client from sliding forward. And then we allow the client's leg that has less available flexion to be at a more open angle. So there are a number of cushions available out there, or this might be something that's built into a molded solution that allow for this asymmetry in hip flexion and extension. You know, lots of clients who have a lot of extensor tone also have hip adduction and internal rotation. These tend to be seen together at the hips. So this is often a result of extensor tone. Sometimes is a result of just simply a loss of range in those adductors. If someone is on a sling seat, well, the legs just kind of collapse into this position. So what can we do? Well, many cushions have a contoured seat. So there's a generic contour to encourage the legs to stay in a better alignment with the hips. But this may not be enough. Some cushions have a deeper contour, a more aggressive contour, or even a leg trough to keep those legs apart. We can also look at medial knee blocks, anterior knee blocks, and even some form of strapping to keep the legs apart. If we use a medial knee block, it's very important to remember that the groin is not a weight-bearing surface. We do not use medial knee blocks to keep the pelvis back. If you look at the picture on the far right here, you can see that this knee block is in the right position. It's between the knees. It should be distal to the edge of the cushion. There are a number of other strategies available. If you notice here in the middle, this specialized medial knee support allows accommodation of a leg length discrepancy. We can slide each pad separate. And on the left, you can see a young man whose abductor is way too far back. It's too big. It's keeping his legs too far apart, and it's right in his groin. Again, we don't want to do that. It needs to be between the knees. If someone has excessive hip abduction, this could be due to a range of motion issue. It could be a result of poor positioning, an overaggressive hip surgery, or even some initial low tone, even if the client develops more extension later on. In this case, we can look at contoured seats again that have a lateral buildup to try to keep the lower extremities in line with the hips. If that's not enough, we can also add on external supports like this lateral knee block. Sometimes a block or support lateral to the hips or to the thighs may be adequate as well. This particular one swings out of the way for transfers if it's in the way of that activity. Now, we mentioned before that some of our clients have this windswept posture where one leg is abducted and externally rotated, and the other leg is adducted and internally rotated. This can certainly be caused by pelvic rotation when we first address this windswept posture, or very specific range limitations, but often is a result of sleep positioning. So many of our clients lack full hip and knee extension, and it's because they spend so much time in a seated position. If that client lays down at night in supine, there's really nowhere for those legs to go, but either both in an abducted position or very often where the legs fall to one side. As a result, we end up with this windswept posture. So it's very important to look at 24/7 positioning when we notice this windswept tendency. With this young man, we were able to come up with a fairly simple sleep system that aligned his legs at night, respecting his lack of full extension in the hips and knees, and actually within several months, this young man had regained his lost range. This same young man in his seating system, during this time, we also provided a lateral block to the leg that was generally abducted and a medial block to the leg that was generally adducted. This, in combination with his sleep positioning strategies, again reversed this issue. Next, we turn to the upper extremities, and we can see a variety of destructive postures in the upper extremities that we sometimes need to address. Let's talk about a few common patterns that we see in people with increased muscle tone. This is a very common one that I'm sure you've seen in your clients, where there's shoulder flexion, elbow flexion, external rotation, and scapular retraction. The challenge with, and also wrist flexion, the challenge with this posture is that the arms often get caught in doorways and our clients quickly lose range of motion. This can be due to muscle tone pulling the joints in these positions. That's very, very common. Sometimes reflexive activity is a part of this. And some clients fix in this position as they're hanging on and trying just to stay upright within their seating system. We need to make sure those clients have adequate postural support. This is a real risk to shoulder integrity, particularly if the arms hang to the side or hang back, as during a tilt, we can end up with dislocated shoulders. So what do? Well, sometimes we can place a pad on the back of the tray or on the back canes or attach it to the back of the seating system so that someone's arms can't fall completely behind them. We can build supports laterally to the arms as well to try to prevent the arms falling off to the sides of the wheelchair. These strategies have limited success. We can even restrain the forearms to keep the arms in better alignment as long as this does not impact someone's function. But it brings up concerns about restraints and can be not very pleasing aesthetically or accepted by the client or others. Splinting and orthotics may also be helpful. But in general, this is a tough position to deal with. It's one that we may be able to deal with in sleep as well. Another common pattern is extension, adduction, internal rotation, and scapular protraction. This can also be caused certainly by muscle tone. There could be a reflexive component. This also poses a risk to shoulder integrity. So what can we do? Well, this is a really tough one to address. We can certainly use strategies to reduce extension in general for the client's body. We can also restrain the forearms if appropriate, and if tolerated, we can also look at splinting or orthotics. Seating challenges at the head. Many of our clients, even who have very high tone in their extremities, do not have good head control. And the challenge here is that the head can fall forward to the side or rotate to the side. We may need to tilt the entire seating system to provide some help from gravity to aid this person in keeping their head upright. And we can provide support posterior to the head, lateral to the head, and even anterior to the head. Now, positioning the head is a tricky subject and one that we could certainly spend a lot of time on. It's very important to perform a full seating assessment. Positioning of the head is very dependent upon the position of the pelvis and the trunk, so we need to address those first. The seat to back angle and tilt in space of the client are also critical to help the client find as much balance to their head position as possible, even if a head support is also required. Here you can see the same young lady with adequate head support. Now her head is upright and midline. There are a lot of posterior head supports or head rests on the market. None of these are going to be effective if our client never touches it. So we really have to look at using these other strategies to assist in bringing that head upright. And again, we can bring in lateral supports and anterior supports even as necessary. In this young lady's situation here, you could see she has a switch mounted by the left cheek. Once her head was well supported, she was able to use her head to hit this switch and control her communication device. So it made a big difference for her functionally. And you can imagine that her vision, her breathing, and her swallow are much improved. So what is our take-home message? Well, in this second part of this series, we've talked about common positioning challenges and strategies to address those in people who have increased muscle tone. We know that positioning people with high muscle tone can be very, very challenging. Optimal seating can help inhibit muscle tone by finding a position that balances breaking up some of that tone, but still allowing someone to sit upright with whatever their potential is for trunk and head control. We also want to always enhance function, never take away from that. Increased muscle tone, movement patterns, and reflexive activity are all very closely related and need to be looked at together in our seating solutions. And we know from part 1 that tone management strategies can also impact seating. And as we'll see in part 3 of this series, dynamic seating can be a critical part of our solution. I want to thank you for taking time to watch this second in our series on muscle tone and tone management and seating. And I want to provide contact information. If you have any comments or questions, feel free to reach out to Seating Dynamics or to me directly. We'd be happy to help you out. Again, thanks very much, and we hope you can join us for part 3 in this series.